Thank you for being here today. I can't believe it's been 5 years since I rejoined the APhA staff as CEO. I remember getting ready for a video shoot the morning we were doing John Gann's tribute. And as I picked up, I was home, and as I picked up the beard trimmer that I use on my mustache, I hit my eyebrow. What I didn't know was that somebody had messed with the mustache trimmer, and I had just shaved off my eyebrow. As I saw it fall in the sink, I remembered words that a good friend, many of you may remember, Sam Kalman. Sam Kalman told me, "Don't be so humble, you're not that great." And so you run with it. Trimmed up the other one a little bit, went in, did a video shoot. Nobody noticed. Nobody cared. So I was very pleased with the results of the survey. So many of you are here for the advancement of our profession, and that's why we go to work every day. Over the years, the last 25 anyway, it's been unusual for the APhA CEO to do a session like this. But this is a remarkable time of progress, unity, and collaboration. So we thought you needed to hear the details from me. But before I start, let me take a minute to recognize all the folks I have the privilege of working with every day. In our staff meeting this morning, I told them that typically when I stand up in front of the staff, it's my job to inspire them, but in fact, they inspire me. Where are they here in the audience? Ask you to stand right now, our APhA staff. There are a lot more of them who couldn't be here because they're out running other programs. But we can all be proud of this amazing team. In my first lecture in pharmacy school, I remember my first dean, R.O. Bachman, who said, "You're now entering a profession where you'll never have to worry about making a living. So worry about making a difference." Now, I just realized, there we go, good. You never have to worry about making a living, so worry about making a difference. Now that's maybe a quote that we don't quite think of quite the same way today. Maybe oversimplified, but it's still relevant. Yeah, we worry, but we are making a difference. And if we fail to make a difference, we won't make a living for very long. If we lack skill, customers will shop elsewhere. Clay Christensen reminded us a couple of years ago when we had him as a general session speaker, as he talked about disruptive innovation. He challenged us to ask ourselves, what is the public hiring us to do? What job do they want us to do? If we don't figure that out, we're out. Somebody else will get hired to do our job. If we don't make a difference in health and wellness, we won't be valued, and the public will seek other solutions. So how's APhA making a difference for you every day with information, education, and advocacy? And I boil that all down to one phrase, and it's a phrase that guides me and our staff in everything we do every day. We promote consumer access and coverage to pharmacists' quality patient care services. Quality is an important component of that. Patient focus, patient-centric, not pay us and we'll do the job, but our patients need access and coverage for our services. The system will no longer reward us for being busy or getting good exercise. The system will reward excellence, excellence in patient outcomes, excellence in patient satisfaction. To quote our friend Clay Christensen again, what we have to offer the healthcare system will never scale unless we make it specific, predictable, and measurable. Now, what do I mean by that? Specific in that whatever it is that we have to offer the system, We can define easily and describe in a way that people understand and can repeat. It needs to be predictable. It's not a one-off. It's not only available in one place, but rather people can go from one place to another, or payers can buy it in multiple places and get essentially the same service. And it has to be measurable so that at the end of the day, or month or year, the folks buying what it is we have to offer know that they're better for it. It has to be measurable. To get there, we need standards and we need quality. But we're gaining the momentum. MTM is growing as a benefit. The evidence is mounting of our value to the healthcare system. Capacity is growing with a highly trained workforce. We're gaining increasing media attention, and it's all positive. The Affordable Care Act has opened doors for us in opportunities for integration. The system must manage costs and improve outcomes, or fall of its own weight. New opportunities for innovation and integration abound. But we've got to be in the starting lineup. We've got to be in the game. And we've got to pursue not just one game, but multiple games or multiple pathways. So those pathways are important: federal, state, and private. And each one of them have their challenges. None of them are a slam dunk. Congressional focus is difficult to maintain. We've got to focus the federal ask on what pharmacists, what patients, what services. Resistance may come from other healthcare professions and other interests. You may think it's easy, but it's not, to maintain unity in pharmacy. This is complicated. There are multiple interests around the table. We've got to listen aggressively to all of those interests and reach consensus. We've got to reach consensus. Pharmacy is challenged to save, not cost the system money. Now, that's unprecedented. A few months ago, I was in a committee, meeting with committee staff, House Energy and Commerce. They happen to have a staff member who's a surgeon. Now, he's very supportive of getting pharmacists plugged in. He says, you know, we really want to help you, but you have to show us that you're savers, not costers. I said, yes, doctor, I understand that. And we've got the evidence, and we'll bring it to you. But tell me, how is it that surgeons showed the system they were savers? He didn't have an answer. No other health profession listed as providers has ever been asked to be savers, not costers. And yet, that's what we're being asked to do. I think we're up to it. Our recognition is growing in many ways. The consumer and trade press alike, Wall Street Journal, New England Journal, Health Affairs. Specifically, just last week, our friend, you just met her, if you didn't know her already, Lee Rucker, wrote a blog post for Health Affairs that got some good traction. And in it, a physician wrote, responding to her blog, MTM is not an attempt to bypass physicians, but to bridge the gap of care caused by high-risk patients who see multiple physicians and are on multiple medications, with often poor communication among providers. Pharmacists are the most competent healthcare providers to manage a patient's medication regimen. That on a Health Affairs blog. USA Today, just last month. With millions of people gaining coverage under the nation's health law, experts say pharmacists can fill gaps in primary care and help avoid unnecessary admissions. Recognition is not only coming from the private sector. CMS is beginning to recognize. We've seen quite positive observations and call letters and other requests for comment coming out of CMS that suggest that they understand that we have something to offer. And while it's not well publicized, we had an important success last year when the medical loss ratio was defined to include MTM as part of the 80% services and quality that health plans must spend from beneficiary dollars, rather than the 20% administrative component of the medical loss ratio. That was a huge, yet largely unheralded win for pharmacy. Thank you. Now, we've had many of you in this audience speak up through White House petitions. There were 2 of them that circulated, and one on change.org and one on We the People, circulated in 2013 asking for recognition of pharmacists as providers. And each surpassed the 25,000 threshold. I think Sandra Leal may be in the audience. She's one of the initiators of the petition, and also Steve Soman, who was a student at the time, now a practicing pharmacist. Both of them we've had good communications with, and really appreciate their advocacy and their activism. Unfortunately, the response to this grassroots petition was a mixed message from the Obama administration. On January 17, 2014, CMS wrote, recognizing the trusted role of pharmacists in healthcare in the community and their importance to patient care, but noted what we already knew, that pharmacists are not providers in the Social Security Act, stating the obvious. Our job is to help them unscramble this mixed message. Now, previous presentations have described how APHA is focused on securing a place for pharmacists on the healthcare team. This has been a pursuit for many years, but over the last 3 years, we began to take a fresh look. We've been part of and helped to maintain, I'm careful not to use the word lead, a stakeholders coalition. You know, when you ask a group of leaders if they want to be led, nobody raises their hand. So instead, we focus on aggressive listening, on really drawing the best out of the group, and investing the staff resources to keep the group coming together and communicating with each other. That stakeholders coalition continues to work today, and I'll come back and share a bit with that in just a minute. But through that, we built a set of principles for healthcare reform in 2008. 3 years ago, we initiated a board task force, which led to last year a pre-meeting summit at our annual meeting, gathering several hundred folks to focus on where should pharmacy go toward this pursuit of provider status. That led to a set of principles on provider status, and now, more recently, to a new coalition very focused on the federal ask called PAPCC, and we'll talk about that in a minute. So, with all of that, I ask, is pharmacy united or divided? And I often hear questions like, or statements, I wish our organizations could work together, like medicine. We wish we could be as united as medicine. Different organizations saying we have to maintain focus on our members' needs. They can never get along with us. They're competing for our members. Or just plain apathy. My employer will take care of that. Well, I'm here to tell you that in my 25+ years of hanging out in organized pharmacy, collaboration has never been stronger than today. We have new principles for healthcare reform. We have a new vision for pharmacy practice. We have a patient care process that everyone is beginning to work through and to discuss, and perhaps to get built into our educational processes. We have principles for healthcare, principles for patient care services. Incredibly important. And finally, a focused federal ask. So there are the Stakeholders Coalition, which is core to all of this, continues to meet on a regular basis. And many of them are here in the audience today. So I'm going to go through the list of the Stakeholders Coalition that's been meeting off and on for the last couple of years anyway, and tell you that it's an honor and privilege to work with each of these folks. Lucinda Main, AACP, and if you hold your applause, ask everybody to stand as I call your name, and then we'll recognize you. Lucinda Main, AACP, Mike Maddox, ACCP, April Shaughnessy, AMCP, Sean Jeffrey and Jeff Del Fuente, ASCP, Chris Jolowski, ASHP, CPNP, if there's anyone in the house, or FMI, Dave Miller, IACP, Alex Adams, NACDS, Mark Riley, NCPA, Becky Sneed, NASPA, Mike Podgorski, Rite Aid, and Dan Luce, Walgreens. Let's give these folks a round for their work and collaboration. Thank you all. The Stakeholders Coalition isn't our only collaboration. I'll show you now just an alphabet soup of collaborations, and I won't go into each one of them. I'll hit on a few of them. But each one of these represents hours of staff time, hours of volunteer time, and a commitment to figuring out what's best for our profession and our patients, rather than what's in the interest of our individual association needs. PQA, Pharmacy Quality Alliance, is all about building measurable ways to recognize quality in pharmacy practice. The Pharmacy HIT Collaborative, that's all about getting pharmacists plugged into the electronic health record with read-write access and the ability to enter into an electronic health record what we contribute to a patient's care beyond what we dispense for them. The Center for Pharmacy Practice Accreditation, which is all about standards. That's a collaboration with ASHP, NABP, and APHA. This Provider Status Coalition that I've talked about, and now a new coalition called the PAPCC. I'm gradually getting used to this new acronym. PAPCC is represented or joined by the folks on the screen. And this coalition is growing. It's relatively new, just the last month or so. But this coalition is very focused on the federal ask and on getting HR 4190 passed. So, what's in 4190? Our government affairs staffs literally go to the Hill together and found sponsors in the House and have folks ready to go in the Senate, but we need to be bipartisan. We need sponsors in committees of jurisdiction on both the R and the D side of the equation before we proceed with the bill in the Senate. That work is ongoing, and we expect good news shortly. But HR 4190 would amend Part B to cover services in state scope that are within our state scope of practice for the medically underserved. We're committed to taking a single message to the Hill that won't confuse members of Congress when they have to deal with thousands of issues, and we want them to focus on ours. Each element of this ask is the product of hours, if not hundreds of hours, of debate, discussion, and consensus building. Work is ongoing now. We've had some work done on the private that we've paid for, we collectively, several organizations, to get a score. You remember the three levers that I mentioned: which pharmacists, which patients, which services. Each of those has an impact on cost. So we had to go to Congress with a decision on those things. And the collaboration that we got to was key in that we recognize that it's essentially all pharmacists providing services that are covered within Medicare for the medically underserved. And each of those have an impact on the score. And the score that we've got, we think, will be affordable And certainly if you factor in the savings and the preventative services or preventative impact, then we think we've got something that Congress can live with. So, you understand the what and you understand the who. Let's talk about the how. In the book Switch, the authors Chip and Dan Heath talk about bright spots. That is, instead of trying to fix all of the problems that we have, let's focus on the things that are working and let's make them better and bigger and scale them up. So, for us, those bright spots are punched up every month in Pharmacy Today. And I'd like to share just one example with you, in addition to the examples you heard earlier today. I love the one that John Vandal shared with us. So, Lynette, not her real name, is a patient in Traverse City, Michigan. Her pharmacist is Kathleen Brown in Munson Community Health Center. Kathleen, I think, is in the house. So, in this Pharmacy Today story, Lynette has a problem. To manage her hypertension, diabetes, and heart disease, she took 16 different medicines. Different doses, different times of day, filled on time, appeared to be adherent. She got all of her medicines when she was supposed to get them. But for some reason her her health failed to improve. Blood pressure wasn't controlled, diabetes wasn't controlled. So Kathleen Brown asked the question only a pharmacist would ask. Not how many or how often, but how do you take your medicine? This was the answer. Lynette put all, I hear the groans in the audience, Lynette put all 16 medications in a bowl every morning. And each time she passed the bowl, she took a handful. It was quite literally pot luck, whether she took her medicine properly or not. Now, I don't have to describe to you all the peril that lies in that bowl. But Dr. Brown suggested something very simple. Get another bowl, one for the morning and one for the evening. Lynette started taking her medicine properly, and her blood pressure quickly improved. Now, the moral of the story is that pharmacists providing care is about more than the metrics. When pharmacists are empowered, we can make a difference. We are capable providers in an incapable system. And that we have the medication expertise needed to help solve what I characterize as a medication use crisis in this country. We have the personal relationships with patients necessary to really connect for lasting change. Now let's talk about the science and the evidence that when pharmacists get involved, costs go down and quality improves. A couple of years ago, we asked our Science Academy, APRS, to pull together the evidence, and they did. More recently, we hired APhA, an important policy shop in the DC area, and an independent voice respected on Capitol Hill, to pull together the value equation for us. That is, take the evidence that APRS had pulled together and punch it up, refresh it, and package it in a way that we can recognize. Several organizations stepped up to support that, and I'd like to thank them right now. ASHP, AACP, ASCP, and ACDS, and NASPA. Now this white paper will be released soon, and along with the release will be the independent confirmation. We've seen the preliminaries. It'll confirm the long-held belief we have the evidence. There's enough evidence out there that when pharmacists get involved, quality goes up and costs go down. As we shared, we're now part of a significant coalition where many of the members are investing significant resources. And for our part, we wanted to build two major pieces. The one you just heard about, the evidence from APhA, and the second, what the public thinks. So we went to find out. We hired Corvus Communications, a large public relations firm, and Claris Research, a highly qualified polling organization, to poll our pharmacists, consumers, and DC Beltway insiders to see what they thought about pharmacists and what we had to offer. And we got a great deal of insight, and I'll boil it down for you here. We began with how pharmacists see themselves. And only 34% of APHA members we surveyed believe the general public fully accepts us as healthcare professionals on par with doctors and nurses. But when we asked the question of the general public, 66% said yes. The general public has greater respect for us as pharmacists than we perceive. The public is ready for our message. They're already predisposed to think of us as providers. Simply, pharmacists are out of sync with what our patients think. But that's good news. Now, people have high esteem for pharmacists, and they're surprised to learn that we're not covered. We asked policy insiders in Washington, D.C. about the message and what they found most persuasive on provider status. Support for provider status increases when you point out that other healthcare professionals have already been recognized under Part B. The issue of basic fairness. Professionals like midwives, dietitians are recognized providers, but pharmacists are not. Once they know that, it increases support for pharmacist status from 58% to 74%. And in my own polling on Capitol Hill, I've found that we can create aha moments when we explain how educational standards for physicians, nurses, dentists, and pharmacists all now require interprofessional education. We're all being trained together. We're trained as teammates. So it's disingenuous for any other professional organization to oppose interprofessional practice. I think that's important. When we polled our membership, particularly on the importance of provider status and their level of familiarity, we not only polled quantity, we also polled intensity. 94% of our members rated provider status as important. Even better, 62% rated it as very important, as opposed to somewhat important. And when we looked at familiarity, the numbers are reversed. 75% say they're familiar with provider status, but only 28% claim to be very familiar. And when we asked about the importance of provider status, our members ranked professional benefits, just as you did in this poll this morning, recognized the professional benefits far above the material benefits of pay and reimbursement. The #1 benefit of provider status, according to members we surveyed, was greater professional satisfaction, followed by better job opportunities and improved status. Increased pay ranked far down on the list. We see that as a challenge for us to educate our own membership about what provider status is and what it means to our patients and the profession and what APHA is doing to achieve it. As Janelle Sabatka challenged last year, put me in, coach, I'm ready to play. And indeed, we are ready to play. We're well-trained and motivated. We're capable providers in an incapable system. Now, APHA is doing its part to support the coalition through the Pharmacists Provide Care initiative. Now, it seems like a throwaway line, but there's a lot of meaning in that. This is APHA's education and advocacy campaign that will be directed at the public, policymakers, and fellow pharmacists. We must influence all three pathways, federal, state, and private. While the PAPCC coalition is focused on federal, we will continue our work in the other sectors as well. Recognition in the Social Security Act will empower pharmacists to provide better care and make the full range of services we have to offer available to patients from pharmacists practicing at the top of their license. Remember the commit card from yesterday? Have you handed yours in yet? If you don't have one, APHA staff are around and will help you get them. Remember, there are 3 million nurses in this country. There are 1 million doctors. There are only 280,000 of us. We need to stick together. We need every one of you, not just you sitting in your seats, but when you go home, the pharmacists you work with. They need to show up too. We've got to recognize the good work pharmacists do every day. We're asking you throughout this meeting and various sessions to share your story. We'll catalog those stories by state. We'll use them when we're lobbying a particular representative or senator to make sure that we're in their state, that we've got state-specific information. So please share your story. We're the solution to the medication use crisis. Every pharmacist has a story about a patient where they made a difference. This is one by John Moscow, a pharmacist with APhA discount drugs on the eastern shore of Maryland.
The greatest story I have is somebody used to come in and he used to test his sugar only at 8 o'clock in the morning. And I said, well, why do you do this? And he said, because I know that's the best it's going to be all day long. So all he was doing was just testing his sugars to make his provider happy and not really looking for the good results. And we teach them how to utilize their meter in a way that they can maximize their food intake, their activity level, and their medications.
Today, I've acknowledged our staff and volunteers and our partners. Talked about where we've come from, where we're going, what we're investing, and what we're asking of you. I learned years ago that we seldom remember the words that speakers say, but we remember how we felt when we heard them. You have the stories to make our case. Share those stories. We have the evidence that supports the case, the Avalier work. The public wants our services and supports pharmacist engagement. The Corvus work tells us that. We have a bill, HR 4190, and a long road ahead of us. My hope today is that you see this awesome pursuit and that you feel it as not just possible, but absolutely necessary. And I hope you feel that you want to be part of it with us. Thank you for making APHA your professional home, and thanks for listening.